everybody. My name is Rehan Anjum and I am clinical pharmacist at Shifa International Hospitals Ltd. Thank you all for joining our monthly C sessions and our aim is to share knowledge among different healthcare professionals. Well, today I am going to take first lecture on our lecture series in nutrition support pharmacy services. As we all are directed toward patient care and as we should play our role in wellness of the patient. In our two-day lecture series, we will try to start from basics, and that will ultimately lead to some professional knowledge. Before starting the disclosure, I have no financial disclosure or conflicts of interest with the presented material in this presentation. So nutrition and so we will start with nutrition and our role. What's the nutrition and why it is required? So optimal nutrition is actually in the hospitals can facilitate better patient outcomes. As I already said, that we are directed toward better patient outcomes. So optimal nutrition in the patient hospital can facilitate better patient outcomes, and malnutrition in hospitalized patient can lead to poor wound healing, impaired immune function, resulting in infection complications, increased hospital length of stay, and overall increased morbidity and mortality as well. As a healthcare professional, we try to promote maintenance and restore optimal nutritional status through design and uh, modification of individualized treatment plans. We have responsibility to direct patient care, including patient assessment, types of feeding designs, clinical monitoring of the feedings, and we also look for the compatibility issues of the different nutritional formulas, either with drugs, etc. We are also responsible for to ensure that parenteral and enteral feeding formula are properly prepared and administered. Let me check with my mic. No, I think so. I am audible. Just wait a minute. I have to check my mic again. No, it's fine. There was a voice issues reported. Okay. It is still slow. Okay, I will try to be loud more. Okay. So, these are the issues while you are online. So our today's learning objectives are to have basic concepts of enteral nutrition, to familiarize with different types of enteral nutrition formulas, as we know that there are different types of enteral nutrition formulas. So how to choose the nutrition formula for my patient, and to know the components of different diet formulas, and to identify the indication and benefits of different formulas. And in the end, we will try to make a nutritional diet plan uh, of with basic knowledge that you will use to provide energy requirement to the patients. I think so. No, I would be fine. So about the introduction, what's the enteral nutrition? Enteral nutrition generally refers to the method of feeding that uses the GI tract. So you can deliver either a trophic feeding in which you are delivering very low calorie just to maintain the gut atrophy and to provide the normal maintenance, normal requirements of the body, but you're not meeting the energy, but you are maintaining the gut. So when your target is the enteral route, that is the mouth and stomach, intestines. So it is the enteral route, and when your target is would be IV lines, then it would be parenteral route. The other question is that is what's the indication of enteral route? Enteral nutrition is used in patients who are at risk of malnutrition, and in whom it is anticipated that oral feeding will be inadequate for 5 to 7 days. So those patients who can't take their nutrition either due to some trauma or due to their disease state, and where you anticipate that he or she will not be able to take nutrition for 5 to 7 days, then there is an indication to use enteral nutrition. And the other question is when to start enteral nutrition. Well, uh, according to the American Society of Parenteral and Enteral Nutrition, that is SPAN, well-nourished adults without excessive metabolic stress can usually tolerate little to no nutrition for up to 7 days. So, like a patient that goes to trauma or a car accident, he can tolerate up to 7 days. But 2016 American Society of Parental and Enteral Nutrition, Society of Critical Care Medication Guidelines says and preface that it is better to start enteral nutrition as early as possible within 24 to 48 hours. So, as a thumb rule, as a general rule, that if the gut works, use it. The GI tract should be used if possible because it tends to atrophy when not used. Gut bacteria can translocate to the circulatory system through an atrophied GI tract and increase the risk of infections. Our primary route would be oral feeding, and it's the natural way of feeding. And remember that nature always creates the best, and it's the best route whenever possible. Use it. But when you are not able to use the oral route, then enteral nutrition route should be used. And in case when your all oral diet methods are exhausted or there's any contraindication to the oral diet, then there's an indication to use the parenteral nutrition. So this was some basics about the nutrition. Now let's discuss the components of the nutrition. Usually, there are two main components of the nutrition that are macronutrients and micronutrients. Macronutrients are those nutrients which we require in a large amount, and these are usually they contribute in providing us the energies, and they consist of carbohydrates, proteins, and fats. And the micronutrients are electrolytes, multivitamins, and minerals. They are needed by the body in very small amounts. However, their impact on the body health are critical, and deficiency in any of them can cause severe and life-threatening conditions. They perform a range of functions for in our body, like they will be used in different hormone synthesis, enzyme synthesis, and in generally what we take in our nutrition, that 40 to 80% of our food is carbohydrate, whether whatever we take, it is bread, fruits, or chicken, etc., though meat is a protein. And 15 to 30% of our diets consist of proteins, and 15 to 30% it consists of fats. So these are the components of our nutrition. Now, what are the contraindications of enteral nutrition? Or you can say it could be indications for parenteral route. So, when there's a complete intestinal obstruction, so when there's a complete intestinal obstruction, you can't feed because there's an obstruction and food can't pass. So, it will make the condition more worse. And GI fistula, if feeding tube cannot be placed distal to the fistula, and if the that fistula is of very high output, that it has a output of 500 ml per day or more, then it is a it's a contraindication of enteral route. And then when there is an extremely short bowel, extreme short bowel could be due to the section of the intestine, or due to extreme short bowel syndrome, when there is a very little functional GI tract available for absorption of nutrients. When there is severe diarrhea or vomiting, or intractable diarrhea or vomiting, because in diarrhea, and there is a very low transit time, that time available for the absorption of the foods is very less. So in that case, you can't use enteral nutrition. The other point number 5, that's hemodynamic instability on intestinal ischemia. This is a very important thing when it comes to ICU, because in ICU hemodynamic instability is more common. Like, but we have to be careful, because we have to think about it. When we are using inotropes, and our body is directed to save its main vital organs like brain, heart, lungs. So in that case, there would be a low blood flow toward the gut. So in that case, there could be a gut ischemia. So if there is a gut ischemia, there would be low absorption of the foods from the intestine as well. Then paralytic ileus, though paralytic ileus many patients can be fed through small bowel despite an ileus as well. The last point, that is the absence of bowel sound, is not a contraindication for the provision of enteral nutrition. Usually, it is thought that there must be positive bowel sounds for a patient to be fed enterally, but it is not an contraindication to provide enteral nutrition. Patient could be fed. So let's discuss about the enteral nutrition administration routes. There are usually large bore orogastric or nasogastric tubes. For quick understanding, for orogastric, there is the route is from mouth. The tube is inserted from the mouth, and for the nasogastric, the tube is inserted from the nose. And gastric means stomach, and it is ending in stomach. And when it is nasojejunal, then it would be inserted from nose and it will end into the jejunum. So large bore orogastric and nasogastric tubes are most common tubes for short-term enteral access. Orogastric tubes are preferred in patients with nasal or facial trauma or sinusitis, but they are uncomfortable for a lot of patients because he might feel irritated. There's a placement of tube in the oral cavity. And these tubes can be placed for stomach decompression in addition to the feeding as well. And prolonged use can can cause sinusitis or nasal mucosal ulceration. Patient with gastric ileus will not tolerate nasogastric feeding, and there is an increased risk of aspiration. And about small bore feeding tubes, I will say that these tubes are most commonly placed through the nose, but they can also be placed orally in patient with nasal or facial trauma or sinusitis. And these are usually used for post-pyloric feeding as well. So other route is that the parendogastric route, or you can say uh, PEG tube, we usually say, or the genostomy tube. In these routes, what we do, that we make directly inserted tube from the body skin. The cut is made to have an entry to the stomach or to the small intestine, or to provide the nutrition. So these were about the routes of administration of enteral nutrition. And about the enteral nutrition delivery systems. When we talk about the enteral nutrition delivery system, there are two delivery systems, that is open or closed systems. In open system, as you see that in enteral nutrition, as you see that in open system, we prepare the drug and we insert it into some feeding bags, like a kangaroo pump. The one at the top left is a kangaroo pump. In closed system, it is just like IV drips we use to infuse, but in this, that the food is already prepared, it is already mixed, and you just have to attach the feeding tube lines, and have to administer it to the patients uh, via feeding tubes or the pumps. Continue. The other methods are their method of giving nutrition to the patient. It could be continuous infusion, cyclic feeding, or intermittent or bolus feeding. The continuous infusion by an enteral feeding pump is usually used in hospitalized patient because of the lower risk of aspiration compared with the bolus feeding. It's a complication, or it's a risk factor for with enteral nutrition, that aspiration pneumonia could occur. But in those patients where there is a increased gastric residual volume, in that case you will prefer to use continuous feeding. In cyclic feeding, usually the food is the nutrition is provided for 10 to 12 hours overnight to facilitate patient mobility during the daytime. The most commonly used method is intermittent bolus feeding. In the intermittent bolus feeding, what we do, that we prepare 100 to 300 ml of whatever the dose, whatever the requirements of a patient, and we administer it in for every 30 to 60 minutes for 4 to 6 hours. Like if you find any order of a nutrition, that please give 3 scoops Q6 hourly. So those are the intermittent bolus feedings. So when we talk about the benefits of enteral nutrition, there could be many benefits that it is cheaper, simpler, and with a fewer complications. But the most important is that with the use of enteral nutrition, you have very low risk of infection as compared to the parenteral nutrition, because as I said that GI mucosal atrophy occurs when there is an absence of enteral nutrition or oral nutrition. So due to the provision of enteral nutrition, gut integrity is maintained, so the bacterial translocation is restricted, so and the infection rate is reduced. There is a contraindicatory study as well where it is said that they have equal infection rates, but all the experts are of this opinion that always use enteral route. The thing is how enteral nutrition formulas differ. You go to the pharmacy, you come across different nutritional formulas. How they differ? What's make them different? The answer to this question is that these are some 4 or 5 parameters that some enteric formulas will be different from each other on the basis of caloric density, osmolality, delivery system, that is what we discussed, that open or closed, and fiber content. Some have high fibers, some have low fibers, and upon the formula composition, that it is available polymeric formula, peptide based formula, or modular. I will discuss these things. No, let's discuss something about Shifa. At Shifa International Hospital, Islamabad, Pakistan, we have following these formulas available. There would be a lot more. There would be a lot more nutritional formulas available outside Shifa International Hospital, but these are some nutrition formulas available. So when we said that formula types, that it is polymeric, peptide based, or modular. What is polymeric? Polymeric is the one in which the food, there's an intact food that is grinded or that is available in the form of powder. So this, and it will consist of all carbohydrates, fats, proteins. So polymeric, or the intact food that is available in the form of uh, powder. So it could be in the form of liquid, as we see that ensure liquid or glucerna liquid. But these diet formulas have intact nutritional components. When we talk about the peptide based or elemental or semi-elemental type formulas, these are the formulas where the all the foods are pre-digested. So as we know that we take uh, everything in our nutrition as a polymeric diet. So we take carbohydrates as a polysaccharide, and then we convert it as in monosaccharide, and then it get absorbed. The same thing is in the peptide based or elemental or semi-elemental formulas. The poly units, the polymeric diet is converted, it is digested into the smaller units. That is, if it is carbohydrate, then it would be fructose forms, or if protein, then it would be in amino acid form. So it is very easy to absorb the food. So these formulas are usually very costly as well. But it is very helpful in patients with very low transit time, or a patient with a short bowel syndrome, etc. The other type of formulas are the modular formulas. As you know, as the name indicates, that these are the formulas that are used to modify the diet. When every formula has a fixed composition, so it's hard for us to have a diet for our patients accordingly. The modular formula usually consists of only one type of nutritional component. Either it would be only carbohydrates, usually, or proteins, or lipids. It would only have one type of nutrition component. Like here we have a Benny Protein Boost. Sorry to mention the name of brands. So the Benny Protein Boost is a diet formula that only contain whey protein. So whenever we require extra protein uh, along with our polymeric diet formulas, so we will add modular. In other instances that we require extra lipids as well, so in that case we will add lipids. So these are the three basic type of formulas, that is polymeric, that intact food, peptide based, that is digested food, and modular, that contains only a single type of nutritional component. And when we talk about caloric density, so caloric density is that this is also I would say it depends upon the patient. And there are multiple formulas. We say that it is 1 kilocalorie per ml, 1.5 kilocalories per ml, or 2 kilocalories per ml. It would help us to have our volume status adjusted, or either let's suppose we have a, at our number 3 there is a Nova Source renal, that is 2 kilocalories per ml. So if we have to give, let's put 100 calories, so we have to give 50 ml of Nova Source. And other one is, the first one is that is 1 kilocalories per ml. So we have to give 100 ml of this food, this nutrition. So in patients where there is a restriction of fluid restriction, so we could use that. Either there is, although there are other differences in these formulas as well. And other things that make them different is their formula composition, that some will say that these have high carbohydrates, these some will have high fats, high proteins, some will have low sodium, like the one above, because we have to use it low sodium, high fibers, if a patient have a constipation, and low phosphorus as well. So these are the composition of our formulas. So uh, we have discussed the type of formulas. Now we discuss how much we have to provide energy to the patient. If you go for the predictive equations for energy calculations, you will find more than 200 predictive equations. So it would be hard for you, that could be accurate for one type of patient, but could not be accurate for all type of patients. So in that case, you have uh, to be careful. According to American Society of Parenteral and Enteral Nutrition, it says that the recommendation A3B says that based on expert consensus, in the absence of indirect calorimetry that's recommended, we suggest that a published predictive equation or a suggestive weight based equation 25 to 30 kilocalories per kg per day be used to determine energy requirements. That it says that if you providing your patient 25 to 30 kilocalories per kg per day, then you're approximately providing the required energy to the patient. So I will say not go deep into the nutritional equations like Harris-Bendit equation, etc. Just if you are going to provide 25 to 30 kilocalories per kg per day, and this is the basic lecture. Hopefully, when you will learn it and you will excel it, then you will know that how to increase the energies or how to decrease the energy for my patient as well. These are the recommendations from different guidelines, like American College of Chest and Physicians says that 25 kilocalories per kg per day and increase by 10 to 20% with systemic inflammatory response syndrome. Society of Critical Care and American Society of Parenteral and Enteral Nutrition says 25 to 30 kilocalories. European Society of Parenteral and European Society of Parenteral Nutrition, it says 25 to 30. So the point is that you have to use it would be fine to use 25 to 30 kilocalories per kg per day. The other thing is you have calculated the energy. The other point is how much protein you have to be used. So for protein, it is usually recommended that if you are providing a body require 1 to 2 gram per kg per day of the protein for to function. As there are many processes going in our body, that is metabolism and catabolism. During the catabolism, there is a loss of proteins as well. So you must have to meet the protein requirement of the patient. Either you are meeting or either you are not meeting the energy requirements for the patient, but you must have to meet the protein requirement for the patient. And it says that usually 1 to 2 gram per kg per day is sufficient for your patient. Usually maintenance includes 0.81 gram per kg per day, and if there is a stress, then your protein requirement could be more, up to 3 gram as well. Patient with kidney function, there was a difference between different guidelines, but it is suggested that you can use 1 gram per kg per day. And you should try to, there's a suggestion to use low protein diet to prevent uremia in kidney patients. And always remember that when you are giving protein, you are also providing energy to the patients. And 1 gram of the protein provides 4 kilocalories as well. So then our first step was we have calculated the energy where we said that 25 to 30 kilocalories per kg day. The other point was calculate protein. Now we are dealing that how to make our nutrition diet plan for our patient. Um, for more expert, you should consult your dietitian or nutrition clinical nutritionist as well. So the first step is you have to calculate energy for the patient. The other step is to calculate protein requirement for the patient. Then what you do that you have to subtract the energy provided by the proteins from the total proteins. So these energy would be known as non-proteinaceous calories. The non-proteinaceous calories are the calories which are provided by the non-protein component of the nutrition, that is carbohydrates and lipids. So the non-proteinaceous component of the food could be divided in any way, that it could be 70% carbohydrates, 30% lipids, and 60% carbohydrates, 40% fats, 80-20, or 100% totally of carbohydrates as well. So then you have to choose appropriate formula that meet approximate needs, and where you have to make a little bit adjustment with your food, with your formula. So our first step was determine energy requirements, and where we said 25 to 35 kilocalories per kg per day. The second step is determine protein requirement, and the third is that non-proteinaceous calories should be divided in patients as per the patient need, where it's our decision, it's our clinical decision that our patient required extra carbohydrates or low carbohydrates or more fats, because it depends. Let's suppose if a patient is of pancreatitis, then we might need low fats. If a patient is of diabetes, then we might use low carbohydrates as well. So we let's make an plan for a 60 kg patient. Let's suppose we have a patient of 60 kg, and we are using 25 kilocalories per kg per day for that patient. We took that we are going to provide 25 kilocalories per day for that patient. Then it is 16 to 25, that's 1500 kilocalories per day we have to provide to the patient. So then the patient protein requirement we took as 1.5 grams per kg per day. So 16 to 1.5 it is 90 grams. So 90 grams of protein would be provided to this patient. When we provide 90 grams, then 360 kilocalories are provided to the patient. So the protein provides 360 calories total. There was 1500 calories. So 1500 minus 360 calories, there would be 1140 calories. So non-proteinaceous calories would be 1140 calories that you have to provide from carbohydrates and lipids. As we said, as in our plan, we took 70% from carbohydrates and 30% from the fats. So 1140, 70% would be 798 kilocalories, and 30% would be 342 kilocalories. So our we have to provide 798 kilocalories from carbohydrates and 342 kilocalories from the fats. So, we must know that usually fats provide 1 gram is equal to 9 kilocalories, and carbohydrates 1 gram is equal to 4 kilocalories. So when we calculate it, that's 798 divided by 4. As I said that 1 gram provides 4 kilocalories. So we need 200 grams of carbohydrate for our patient, and the same way we need 38 grams of fats for our patient. So in our patient we need 90 grams of proteins, 200 grams of carbohydrates, and 38 grams of fats. Then our nutritional needs would be met. So let's discuss. Now we will take different nutrition formulas, and we will say that see their composition. Let's suppose these are some nutrition formulas, that is isocal, Ensure liquid, amino levan oral, glucerna powder, or resource diabetes. So for the provision of 1500 kilocalories, you will require 319 grams of isocal powder and 350 grams of Ensure powder, or 100 ml of Ensure liquid. So when you provide 1500 kilocalories from isocol, you will use 319 grams, but your protein would be 49 grams in it, 188 grams of carbohydrates, and 62 grams of fats. In case of Ensure, in 350 gram of powder, which is meeting our energy requirements, there would be 56 grams of proteins, 201 grams of carbohydrates, and 49 grams of fats. In our Ensure liquid, via 1000 ml, it contains 64 grams of proteins, and carbohydrates 200 grams, and fats would be 42 grams. So in the same way, we compare all these nutrition formulas, and we will decide that which one is approximately meeting our needs. In this case, Ensure liquid is meeting our needs, but it is falling short by 26 grams of proteins to our requirement, because we need 90 grams of protein, and there is a 64 grams of protein. Carbohydrates and fats are approximately same. It's not possible that you can get exactly the same diet for your patient in 90, 238. So if you're going to change it a little bit, then it would be might be 68% of carbohydrates and 32% of lipids. And that's completely fine, and there is option that if you are going to make change, and there might be some 50 to 100 kilocalories addition, or less calories provided to the patient. So if I choose Ensure liquid, then in this case there is a less protein, and I know that there are formulas exist known as modular formula, that only contain one type of nutrition formula. It contains proteins. So if I take if I can provide 26 grams of protein by my modular formula. So for this patient, I could be ordered that we have to provide 1000 ml. So yeah, I could divide it into four frequency, four times a daily. That 250 ml Q6 hourly will provide me 1500 kilocalories, but protein would be less. 250 ml Q6 hourly, it would be 1000 ml. So, and for protein, I would add separately, that is 13 grams of bene protein, or 13 grams of protein twice daily. So this was a simple calculation. So, you can make following type of charts or brochures, because it's very hard for you for anyone to remember the composition of the charts. This is the one where we made at Shifa International Hospital, and we find it very helpful. It contains all the nutrition formulas, their composition, how to prepare, and serving. This could also help nursing as well, and dietitians or physicians, pharmacists, everyone. So you can make a one for your organization as well. Yeah, this is the background information for our comparison. Like if our physician asks for a patient without nutritional diet with a low sodium content, so we have a comparison of all the drugs, sorry, all the nutritional formulas. So if someone is saying that which nutritional formula have low sodium content, so we can easily say that okay, Nova Source has very low sodium content as compared to other. So the same case is for other nutritional diets. So when we talk about that disease-specific enteral nutrition formula, yes, it exists that for a specific disease you can use specific type of nutrition formula. It is based upon the guidelines that in such nutrition formula you have to use high carbohydrates, high fats, etc., etc. It's high caloric, low phosphor for patients of renal failure. Enteral form are you the renal failure patient usually required a diet plan with high caloric density and low volume, and contain different amounts of protein and electrolytes, like Nova Source Renal, NAPRO LP, and there is also other one, NAPRO HP, with a high protein as well. For respiratory patients, usually they have more fats as compared to the carbohydrates, because it is said that due to the metabolism of carbohydrates, and due to as we know that fat of the carbohydrate is ultimately water and carbon dioxide. And so, in the patient with acute respiratory distress syndrome, there could be a situation arise of hypercapnia, that patient trying to retain carbon dioxide, so it could worse the patient. But recent guidelines says that uh, The more culprit, saying to, calling to the carbohydrates, the overfeeding is a more culprit. So in patient of acute respiratory distress syndrome, you should also be careful about avoid overfeeding to the patient. When we talk about liver failure, hepatic encephalopathy, there is a difference. In 2009 guidelines, it was strongly recommended to use more branch chain amino acids, but in 2009 guideline, 2016 there is a changes about the use of branched chain amino acids. Internal nutrition formulas for patients with hepatic failure or and hepatic encephalopathy contain more branched chain amino acids and fewer aromatic amino acids. Which may improve encephalopathy. It's a controversial statement, but are not commonly used. So, the 2016 guidelines says that if you are using more branched chain amino acids, then the process of cirrhosis could be delayed, but it's not going to prevent it. For in diabetes patient, we might use more fats, low carbohydrate, more fibers, or the diet with lower glycemic index. So we have example of resource diabetes, glucerna powder or glucerna liquid. When we talk about the immunomodulating formulas, yes, and there are also different types of. In 2016 Aspen guideline, it was though not recommended, not strongly recommended to use immunomodulating formulas. There is not a preferable use of immunomodulating formulas, but with time there are multiple publications showing that there is a great benefit of using immunomodulating formulas. Then immunomodulating formulas are recommended for surgical ICU patients, but these are not recommended for medical ICU patients. These internal nutrition formulas are designed to improve immune function and clinical outcomes. It usually contain arginine, glutamine, omega-3, or nucleotides, or like beta carotenes, etc. So, but specialty formulas are not recommended for routine use in general ICU settings. So we have some background knowledge. Now we discuss that how to develop an internal nutrition regimen. The same steps will be followed. Like you have to determine caloric requirements. You have and follow it like the protein requirements, non-proteinaceous calories. You have to choose formulas and then determine infusion rate and ensure the patient receives sufficient protein and ensure patient receive proper water. So let's suppose that is energy requirement 25 to 35 kilocalories per kg per day. We have choose the formula, disease specific, or we will choose according to the differentiating parameters of the nutrition formula. And then we will say that how much volume we have to infuse and how we are going to infuse it, whether it is an intermittent feeding, or it's cyclic feeding, or it's a continuous feeding. So let's put it's a continuous feeding for 1500 ml, it would be 62.5 ml. Then we will check that how much protein our patient is receiving. If it's not receiving the adequate protein, then we will add the proteins. And last but not the least, you have to find the water content, that how much water required for our patient. Usually 30 to 35 to 40 ml per kg per day is the requirement for water to the patient. So let's discuss about the complications of enteral nutrition. So there could be improper tube placement of the tube, clog feeding tubes. That could be prevented by flushing the tube before, between, after the administration of each drug. The use of liquid formulation of um, medicines is also preferable, and if available it is also recommended. Unclogged tubes with warm waters or pancreatic enzyme solution mixed with sodium bicarbonate could be used for clogged tubes. And we should avoid using a cola or juices via tube feeding. Aspiration, that's a very dangerous consequence of enteral nutrition. So to avoid the aspiration, you should have the patient should have 30 to 45 degrees to receive enteral nutrition. That is a head of bed elevation. It should be 30 to 45 degrees. And you should prevent delays in gastric emptying using an international formula with less fats. Gastromotility could be increased with uh, GI motility increasing agent like metoclopramide or erythromycin. Metoclopramide and erythromycin can be combined, but you should be careful about diarrhea and tachyphylaxis and avoid prolonged use of promotility agents because of increased risk of adverse events. Uh, uh, due to the formulation of the nutrition formula, that it can contain different amount of osmolarity, so it could cause diarrhea. So and it's more common with a higher osmolar diet formula. Consider other causes of diarrhea as well, because a patient in ICUs, or he could be lactose intolerant, or he's receiving a lot of antibiotics, or he could develop C. diff as well. So you can't only say that nutrition is responsible for diarrhea, but you should look for it. And constipation could be prevented by adding fiber or bowel stimulant in our diet. And the last one is dehydration. So in dehydration, we should be careful that patient may develop hypernatremia or electrolyte imbalances. You should provide adequate water to the patient, as I have said, that 30 to 40 ml per kg per day. So or in case if there is a patient with fluid restriction, then you should use a caloric dense formula, that is the one with the 2 kilocalories per ml or etc. You should also look for nasopharyngeal erosions, epistaxis, or tracheoesophageal fistula, sinusitis, and electrolyte abnormalities. So drug administration using enteral excess, I have to go it through quickly. Uh, Liquids are preferred, and they should be diluted with 2 to 3 times the medication volume with water to decrease osmolarity. Diarrhea can occur with medication. Having high osmolarity medication mixed in sorbitol can cause diarrhea as well. Always flush the tubes before giving administration, and don't give the drugs that are enteric coated, extended release or sustained release. Don't crush them and administer them via enteric tube. Look for the formulation that is not enteric coated or etc. Always give your feeding to medication with 10 to 15 ml of water separately. It may be necessary to discontinue tube feeding before and after drug administration temporarily to prevent reduced bioavailability, like in case of fluoroquinolones, phenytoin, warfarin, bisphosphonates. Consider feeding tubes location and subsequent drug absorption for efficacy. Antacids needs to be administered into the stomach, not to the duodenum. So you are open for questions. In our today's session, we will not take questions directly to answer. We will answer these questions in our tomorrow's lecture of parental nutrition. After that, we will answer all the questions in detail. So if you have any question, please write in question and answer box. So and that's end from my side. If I can answer 1 to 2 questions quickly, I will. You can type questions. You have time to type questions 3 to 5 minutes, and for you that I don't consider that knowledge is a copyright. So in tomorrow's lecture, I will share my presentation link with you as well. I will share it tomorrow after the session, and the link for this PPT as well. These are my references for this presentation. Thank you everybody for listening to us, for joining us, and hopefully we will be connected tomorrow and I will answer all your questions. People are typing questions, so I am giving 1 to 2 minutes more for you to type questions, and I will reply you inshallah tomorrow as well. And if you want to receive it via email, then you can type your email as well. Okay, now I am about to close it. Thank you, everybody, for joining us. Hopefully, you will join tomorrow as well, and we will discuss these things in detail as well.